So I want to thank Giovanna and DUPRI for giving me the opportunity to give this talk. As I was saying, I think this talk is extremely timely. This is something, the notion of making electronic health records data at Duke accessible has been a strong interest of groups I've been part of here in the School of Medicine. And there has been a lot of development over the past, really just even few months in making this process better. So just for some context on myself, I'm faculty, as Giovanna mentioned, in Department of Biostatistics and Bioinformatics, and most of my work is around methodologically, how best do we work with electronic health records, what are challenges and opportunities in working with these data. I find them to be a really exciting data source. I've probably been working with them. I was randomly introduced to them about 8 years ago or so, and started on one project and have since really gotten hooked and just have found a myriad of really exciting and interesting opportunities. And in my time here, at Duke, one of my big interests has been, how do we make these data more accessible to more researchers? I think the wealth of questions we can ask and answer with these data extend far beyond just clinical questions. Some collaborations that I'm doing with Giovanna and her group are much more around demography and sociology, and I think there's a lot of interesting opportunities to use these data. So I'm really excited to see kind of and I'm not surprised to see the breadth of people who are here today. Just as a brief outline, I'd say the first half to 2/3 of the talk will be more about what are EHR data, the structure of them, some analytic challenges. If you're really interested in this final topic, and I would understand about how we access EHR data, I'd completely understand. If you want to tune out for the next 45 minutes or so, you're more than welcome to. And then the last 20, 30 minutes or so, we'll really talk about what are options for gaining direct access to EHR data. So just to really start from the basics, so what are electronic health records? There's lots of different definitions. I like this very general definition from CMS, which is an electronic health record is an electronic version of a patient's medical history that's maintained by the provider over time. It's clean, it's simple, but it's very general. So it's a compendium of what is the information that we see about patients who come to see a clinical care provider. The reason there's been such a growth of EHR data over the past decade is that a part of the stimulus, if we remember our last recession, there was what was called the High Tech Act, which was part of the 2009 stimulus, and it was geared to incentivize the use of EHRs. In the literature, you'll often see EHRs used synonymously with EMRs, electronic medical records. In Europe particularly, you'll see the reference to patient health record, PHR. I had an early mentor who really preferred the term EHR over EMR, because to him, saying health record as opposed to medical record really highlighted the fact that it was a record that was holding on to not just medical information, but all aspects of health. So when I talk about it, when I write about EHR data, I'm very particular to only use the EHR moniker for that reason, but they're exactly synonymous with each other. As I mentioned, so here we've had EHRs for a while. Duke has had an EHR system. I want to say the first EHR systems go back to the 70s. Duke has had an EHR system since the 80s. Here is where we have the High Tech Act, and we see, and this is only going back to up to 2015, but we see just this continual growth of the use of EHR systems. It's important to keep noting, we're not going to go in, I'm not going to go all into this, but I want to make sure it's clear that there's a lot of different vendors for EHR. So the vendor that we use here at Duke is Epic. This is the largest vendor for academic or large medical centers. But then you have a lot of different types of vendors, particularly health-specific vendors. So Allscripts is a vendor for prescription medication. You have vendor Cerner is another academic healthcare one. Practice Fusion is more for outpatient practices. So you can almost think about EHR vendors as different types of operating systems. You have Microsoft, you have Apple, and in the same way you have a lot of different types of EHR vendors which create their own types of platforms. This is just a kind of a generic screenshot. This is not what we see in the front of it. This is an illustration of what a doctor here that you're dealing with in a medical appointment will see and will be interacting with. So this becomes a way for the doctor to be able to organize all of the patient's information. So what we have is information on the patient in front of us. We have we have an address. We made the information on what's been ordered here. This patient was ordered an EKG. Here's some information on billing. You can click on tabs to look at prescriptions. You can click on tabs to look at what kind of lab information. But the entire notion of an EHR is, well, I would argue that there's two big goals of an EHR. In a cynical view, you can say that it's to organize it for billing and to make billing more efficient, and that is definitely a big part of EHR data. In a less cynical view, it's a way to make care more efficient and to provide information back to doctors and providers so that they can better collate the information that they have on their patients. I always think back to my father, who's a surgeon and has hundreds and hundreds of paper charts and filing cabinets, and I can't imagine how you would actually look up an older patient and get information on them. This becomes a way to organize that information. But one of the themes that I'll talk about here is that what I'm not mentioning was an intention of EHR data is to organize it for research purposes. And so newer EHR systems, Google's starting to get involved in the EHR space, and they're thinking about this now for research. But the original EHR systems, they were not designed to make researchers' lives, our lives, easier, and that does raise some various challenges throughout that it's important to be cognizant of. The back end of this, and this is actually it's a slightly older illustration of the architecture here at Duke, of what the back end of the EHR system looks like. I'm not going to go through this slide, and really the point of this slide is to make it clear how complicated this really all is. We have our enterprise data warehouse, we have modules that work off it, we have different data sources that are going in, and the data are flowing through lots of different places. Once you appreciate the fact of the complexity of the back end, it becomes clearer why we can't just say, let's give people access to EHR data. It's really not a possibility. And to get access to these modules, for example, the Clarity backend of Epic, you need to go up to Verona, Wisconsin, which is the headquarters of Epic, take an approximately $10,000 training and become certified. And and there's a lot of it's not just a money maker. There's really good logistic reasons why that needs to happen. You're working in the back end of an extremely messy infrastructure, and if you work around in there and you don't really know what you're doing, you can cause some problems. And so really the goal of the health information technology services here at Duke is not to give people access to this backend, but to try to create services and to create abstractions of the data that are easier and accessible for folks to use. This kind of gives another illustration of what we have in terms of how the data are organized. So this is about the Epic backend. So this is again what we use here at Duke. There's actually a series of different layers of Epic. So we have what's called chronicles, which are data that are stored immediately. These are stored in a very raw, disorganized form, and there's about 95,000 data elements. These data are organized overnight into a system called Clarity. You often may hear people talk about Clarity data. This is still quite complicated. There's about 17,000 tables. A number of those tables are deprecated, but there are 17,000 tables. So if you don't know what you're looking for, you probably won't find it. And that's 17,000 tables over about 125,000 columns. There's a newer offering by Epic to simplify this a little bit more into what's called Caboodle. Caboodle takes those 17,000 tables, organizes them into about 19 tables and about 76 dimensions. So this is something that is much easier and much more accessible for folks to work with. From here, we can start thinking about now what can we do with the data. We can create things like disease-specific registries. We have things like the diabetes registry and atrial fibrillation registry. We can create analytic tools, provider dashboards, predictive models, etc. So the key here is that the data with which you're dealing with are not necessarily the rawest of the raw data. And the reason I like to really talk about this is because when I first started working with EHR data, particularly EHR data here at Duke, I would tell the people who can provide me data, I would just say, just give me the data. Give me, they'd ask me what I wanted, and I'd say, don't make any choices for me, just give me all the data. Being a naive statistician, I kind of thought I wanted everything and I would make all my choices. And I have a friend who works in the team, and she provided me the data, and I realized, and she laughed at me when I came back and said, I can't do anything with this. And that was kind of the beginning of my insights and realization that we need to deal with some of these abstractions. We can't deal with data here, or really even data here. We need to deal with data in some more organized ways. And when I get towards the end about how we access data, I'll talk a little bit more about how some of those tools we've created here at Duke allow you to more efficiently deal with data. Okay. So what I'm going to go through now are really just almost a tour of various types of data elements, and just kind of to give you a sense as to what's actually within the EHR, and hopefully get you excited about working with some of these data. So the most basic form of data that we have are demographic data. Each patient have a single ID that follows them across all encounters. This is referred to as a medical record number, or an MRN. It is possible that a patient will come in, and if they're coming in an emergency context, a new MRN, there won't be time to look them up in the system, and a new MRN will be generated for them. There's about 5, and there's actually software that operates within here, and there's some projects I've been involved in here where what we actually look for is duplicated MRNs. And I want to say about every month there's about 3,000 or so duplicated MRNs that are created where the charts need to get remerged together. From a researcher perspective, that seems crazy, and why would you do that? But from a healthcare provision perspective, if someone's coming in an emergency, you don't really want to waste time of figuring out, do I have a chart on them? You just want to get them into the system and begin working on them. So you just create a new MRN for them. The demographics cover your basic information, your age, your sex, your race, ethnicity. These are typically static. You can think about your time varying elements, who the payer is for that encounter, was that paid for by Medicare, Medicaid, Blue Cross, what your address is, particularly when we think about population health, knowing where people are living is extremely powerful and important. The next level of information that is important for most analyses are encounter types. Encounters have an encounter ID that links the encounter to what happened. So, and that's kind of where we start getting into the meat or the guts of what we really care about. We can think about 3 basic types of encounters. There are outpatient encounters, which may also be referred to as ambulatory visits. We will have inpatient encounters, so that's an encounter in the hospital, and then we'll have emergency department encounters. And obviously, a lot of these can flow together. So you may start in the emergency room, and then you get transferred into the inpatient. You may have an encounter that starts in urgent care in an outpatient setting, and then you're told to go to the hospital. So we can follow people across these encounters. Particularly now in the time of COVID, but even before COVID, we can think about other types of encounters, telephone consults, emails. These are all captured. So every time you email your doctor, that's captured within this system. As we move to an era of video consults, all that information will be captured. And now we need to think about, as researchers, how do we organize that information and use it and study the effects of those. When we think about information for encounters, we can ask questions about, for example, when someone was seen. So we often have timestamps for arrival and departure. We can think about who the patient saw, so who the provider was, and the provider type. We can know where the patient was seen, the clinic location, the type of facility, and we can think about what happened, the vital signs that were taken, the labs that were taken, the diagnoses made. The most important thing, though, that we don't have is we don't have good information on why. And the reason for that is that while we have diagnoses, those don't often relate to a chief complaint. So there isn't, unfortunately, a structured field really within the EHR that says, why is the patient here? that finds itself in notes, that finds itself within a clinical narrative. And while there has been a lot of advancements, and a lot of advancements, particularly here at Duke, within the AI space of doing natural language processing and analyzing those notes, those data don't exist in what we'd call a structured or easy to access form. We can understand the when, the who, the where, and the what, but that why is much harder to infer. As we move into the encounter, we can start thinking about, okay, so how do we actually code what happens? So a number of you may have heard what are called ICD codes, or International Classification of Disease Codes. This is a hierarchical system to code all diagnoses that are made during a health encounter. So this kind of refers to, it can give you a notion of why someone is in here, but also relates to kind of what's going on with them. In 2015, the US switched to the ICD version 10. Previously, we were on ICD version 9. This switch happened in October of 2015. And in Europe, this happened a little bit earlier. We're already in the process of switching, of looking at what ICD 11 will look like. And this, again, this has made researchers' lives incredibly complicated, but it's also what keeps researchers in business, or academics in business. So ICD 9 had 13,000 unique codes, where ICD 10 has 68,000 unique codes. And I'd love to say that there are some direct mappings here, at least a one-to-many, but there isn't even a one-to-many here. So so this process of mapping between ICD 9 and ICD 10 in some contexts can be quite challenging. It's important to know that since these are often used as billing codes, so this is the basis for our healthcare reimbursement system, the codes can be manipulated to increase billing. It's what's interesting. I was working with folks over at Duke Singapore and their health system there, and actually one of their complaints that they had from a research perspective is that because diagnosis codes are not attached to billing in Singapore, there is actually very poor capture of diagnosis codes. So one of the side effects, if you will, of our healthcare system and the billing system for our healthcare is that because there's such an incentive structure to get these diagnosis codes right and accurate, they actually get these codes right to make money. They actually are quite accurate. You move to a system that doesn't have that type of incentive structure, doctors aren't going to be coding in the same way. So we have at Duke teams of people whose job is to make sure that the diagnosis codes are accurately reflect what happened. So there's a much different fidelity than what you may have in a different type of healthcare system. But again, it's important to know that these don't always represent the primary concern of the encounter. To try to understand a little bit more about this, so this is the structure of ICD-10. The beginning always starts with a letter. This is new in ICD-10. We'll have 2 numerics, a decimal point, and then more numbers. And I mentioned this is a hierarchical system. So we may say I-21 refers to acute myocardial infarction, where subsequent numbers will designate the location of the event. So I-21.01 would designate that this is an MI of the left main coronary artery. 0.02 may designate something, a different part of the MI. As researchers, we don't typically care about where in the heart that myocardial infarction occurred. So what we'll often say is, all I care about is the I-21 stem. So in coding language, even you say I-21 star. And anything that comes after this, if I want to find someone with a myocardial infarction, anyone that starts with an I-21. But as you're thinking about this as how you may code this out or pull these data, you need to be cognizant of that may be 0.01, 0.02, or just I-21 with just a stem. I-22 would be subsequent MIs. I-23 are complications of MI. So there is an order and a logic structure. I'm going to try to pull up a more specific example about. So so this is a website I often find myself on where I need to look up codes. So we want to look at I-21, and then we can look at and now we can see. So this should give me all of my different. So this gives me information on these codes and all the different codes that are related to it. And now I have all my different stems. So I have my I-21.0, which is for interior walls, 01, left main, 02, left interior, basically all different parts of the heart where that heart attack occurred. So again, if in general, I would trust that that I-21 stem is quite accurate. The fidelity of this may be a little bit less, and this may not be coded as directly, because this first part is really where the importance, again, from a billing perspective, comes in. We can think about rolling up codes as well. So dealing with 68,000 unique codes is not realistic or efficient. When there's a number of different proposals for how codes can be rolled up. The one that I find myself particularly using the most is one that was developed by ARC, called the Clinical Classification Software System, or CCS. And it allows researchers to roll up codes to appropriate level. So you can say, give me all, this is a way to say, give me all the codes that relate to coronary disease. And now you can say, because all I care about is, does my patient have a history of cardiovascular disease? I want it to say, these are the suite of codes I care about. Or do I care about, or give me all the codes that relate to a bacterial infection. And now you can, and this gives you ways of grouping codes together, again, to make life as a researcher a little bit more efficient. ICD codes are diagnosis codes for what essentially we think is wrong with the patient. Then we also have what are called CPT codes, or current procedural terminology codes, which really relate to what happened during an encounter. So this may include surgeries, x-rays, etc. There's about 10,000 in use. These are also tied to reimbursements. And again, there's similar systems for organizing CPTs as there are for ICDs. I'm not going to go into as much detail, but again, so we have codes for the diagnoses that are made. We have codes for various procedures or things that happen to patients. Another table of interest, if you will, are medications. So EPIC has over 100 medication-related tables. So it's not just as simple as saying, I want to look at the medications. You want to know what kind of medications I want to be looking at. A lot of the reason we have these different tables is because medications can come from different places. So I may think about what medications were ordered, but if that order happened in the hospital or happened at an outpatient clinic or was referred in, those data need to be organized in a slightly different way in the back end. So as a researcher, I may not care about all those nuances of where those data come from. I just want to know what orders does a patient have, but on a back end system, we need to keep these a little bit more organized and spread out. Typically, we can think about medications in 3 different ways. What medications were prescribed? This is, again, that's not taken, so we don't often see good information on what was taken by the patient or even bought by the patient, but what was ordered by the doctor. So almost more of an intent by the doctor. Medications that were administered, this would be, for example, in the hospital, if you were given an IV antibiotic, that'd be an administered medication. And then we also have what's called medication reconciliation. So every time you go to your doctor and the doctor asks you, are you still taking this drug? That finds its way into a medication reconciliation table. While we do have dosage information, and a lot of times in my experience, that information is captured with less fidelity than the actual order itself. So we have good information typically about what was ordered. The dosages are not, can be a little bit messier. So depending on how important it is for your research study, you want to be careful about how you're working with that. And again, there's a lot, like diagnoses and procedures, medications can become overly granular. So there are systems in place for organizing and rolling these up. The one that I tend to use the most was developed by the National Library of Medicine, part of NIH, is called RxNorm. And this gives, again, a way of creating a hierarchical system for understanding medication. So this is the RxNorm page for acetaminophen, commonly known as Tylenol. And all of so this here, this 1041528 is the RxNorm code for acetaminophen 10 milligrams per mil. There's a different code for 100 milligrams per mil. There's a different, so I may not, again, as a researcher, all I maybe care about is, was my patient prescribed acetaminophen? I don't care about particularly the dosages. So I may want to do my query and say, pull all of the data that has any of these RxNorm, or it's called RxQE codes. We can also think about these again, within a hierarchical system. Okay, yeah, so you can think about these within a hierarchical system where we have acetaminophen. Acetaminophen is, these are kind of class of opioids or analgesiacs, and we can look at data within the hierarchy. So if I wanted all analgesiacs, I can click into here. If I wanted all versions of acetaminophen or tramadol or acetaminophen and codeine, I can look in here as well. So again, there's different ways of thinking about these data within a hierarchical structure that will change depending on the research use or research question that you have in mind. Okay. Laboratory tests and results. So I'd say that the first sets of data, your demographics, your billing codes, your CPT codes, even your medications, these are not particularly unique to EHR data. So for anyone who's worked with administrative data, data that maybe come from insurance companies, come from Medicare, Medicaid, you'll often see these data. You'll see things in a little bit more granularity with the EHR data. You won't often see dosages within administrative data. You may not get addresses or some of the refined information from administrative data, but you'll see a lot of this information where EHR data start becoming really unique and powerful, or when we start talking about some of these other data sources. So laboratory test results are one particular one that really begin, and vitals are the other, which really begin to differentiate EHR data from administrative data. And particularly what's interesting about these data from a research perspective is that this is really what differentiates what happened, what a doctor did, from what is actually going on with the patient. What is the underlying condition? What does the patient look like clinically? And it can start opening up the door to research studies that not only look at what does the doctor think, because a diagnosis code is only as good as the doctor. If the doctor misses the diagnosis or doesn't do the right procedure, then you're not going to see it. But if you have these other clinical variables, as a researcher, you can start thinking about, well, what else seems to be going on, and maybe can I find some other clue or signal in the data that wasn't there based on what the doctor saw. Now the caveat in that is, of course, and this is something that within my research group we've studied a fair bit, is that that's still conditional, if you will, on the doctor performing the lab test. So there is still this notion of intention and informativeness within the data, that if that someone's lab value may be out of range, but if the lab test was never taken, we'll never see it. So it's not a perfection, but it does give us more insight into the patient condition. As we think about these data, it's important to note that there may be multiple test panels used, which can be labeled differentially. Modern systems have standardized nomenclature of laboratory test results. Duke itself has a catalog of the laboratory tests that are used. So this is found here at testcatalog.duke.edu. And if you did a search, for example, for creatinine, which is a typical lab test to look for kidney function, you will find, what's nice is we have these lab codes, so you can look for any of these lab codes. The problem is that if you're not a clinician, and I'm not a clinician, I can't tell you the difference between all of these creatinine lab tests. You may end up looking at the wrong one. So this is really where I start emphasizing the importance of having good team science, so that you're working hand in hand with somebody who has a deeper understanding and maybe knows the difference between a creatinine and a creatinine whole blood and a creatinine 4-hour load. I personally don't know the differences. It may be that they all tell you one and the same. It may be that they tell you something slightly different. So just looking for a creatinine test, it is not as simple as you would think it could be. Okay. Typically, we see timestamps for when a test was ordered and resulted, and an analytic concern is that these, so that can again become really powerful if we're thinking about data, particularly within an inpatient setting. We see a lot of the timing of things. That's again a distinction from administrative data, where you just kind of see a summary of the encounter. And an analytic concern is that these measurements are often irregularly captured across encounters. So that's where that informativeness comes in, where as a researcher, I would love that you had your creatinine taken at every health encounter. In reality, your creatinine is really only going to be measured when the doctor thinks it ought to be measured. Okay. Vital signs are similar to lab tests, and again, it's really what begins to differentiate EHR data. Most encounters will capture things like blood pressure, weight, and temperature. In the hospital, vitals may be documented every couple of hours. So some of the projects I've worked on, particularly around predictive modeling, will really utilize this aspect that we're seeing a patient's blood pressure every 2 hours, and then we'll use that to develop models for risk of decompensation or risk of mortality, because we're seeing what's changing in a patient over time. As we start thinking about other areas of the hospital, so for patients who are in the intensive care unit or the ICU, monitors can capture very dense data. So I'm currently working on a project right now where we're looking at ICU data for traumatic brain injury. We know we're gonna have data stored on a minute-by-minute date aspect. And for some of these vitals, we can get these even at a waveform level. So for those who are interested in more like a signal processing perspective, you can get really dense granular information on how these vitals are evolving in continuous time. The data themselves will often be stored in what are in long running tallies called flow sheets, which are they're a very general data structure that's efficient for capturing things as they occur, but they're not very, again, they make life challenging. As a researcher, I was talking to a colleague yesterday who had to deal with flow sheet data, and just kind of walking through that the challenge of these. They are not organized, again, with the researcher in mind. They're organized with the mindset of how do we just efficiently, as quickly as possible, store a running tally of every minute what your blood pressure is. Again, as we start broadening out now from the medical to really the larger notion of health, we can think about things like social health. So data such as smoking status, drug and alcohol use, employment status, marital status, etc. There are fields for all of these. They may be reported, they may be, I would personally consider them unreliable. I've used them in studies here or there. It's something, to me, this is where you start getting into that caveat emptor of, know what you're getting into, do some quality checking of the data. In general, I would presume that if something is there, it's correct. Someone's would not be listed as being a smoker. Typically, if they're not a smoker, it's more the opposite that may not be incorrect. So the absence of something, typically we have to rely on the absence of something, meaning that it doesn't exist. And so if the absence of an MI in my health record is probably a good indication that I've never had an MI. The absence of drug and alcohol use in my health record may or may not indicate that I have a history of drug and alcohol use. I personally don't have a history of drug and alcohol use, but that being said, so socioeconomic status typically doesn't exist. But again, as we start thinking about population health, there are some really powerful proxies that we can use. So we've done, with a colleague here, we've done studies looking at Duke. We found that really just even knowing something about primary payer and one's socioeconomic status, primary payer and race tells you a lot about their socioeconomic status. So if someone is on Medicare, then on Medicaid, then they're more likely to be poor. Also, neighborhood addresses can be quite powerful. We've been doing a lot of studies lately of leveraging things like American Community Survey data, where you can map where somebody lives and then use ACS data to get an understanding of their neighborhood SES. There's also growing emphasis on capturing patient-reported outcomes, or PROs. Again, these are not being captured. These are not being collected with consistency, but I think in the coming years we're going to see these growing more and more. Things like metrics for food insecurity, the promise is a very popular metric, pain inventories, depression inventories. And again, this is where I think data start becoming really interesting and powerful as we get more context of not just the medical situation of the patient, but the overall health status of the patient. There's lots of other data elements, and I don't want to bore you by kind of going through in too much detail on everything. We have notions of what are called problem lists. These are date stamped indicators for when someone has different conditions. They're frustratingly unreliable because there's no, and I'll talk about this a little bit later, but there's no notion in the EHR of, for example, who has heart disease. And the problem list is meant to solve that in some ways of saying you have heart disease. They're just not always well captured. They're not always kept well up to date. So it's something that we've used at various times with varying degrees of success. There is what are called ADT data, or admission, discharge, transfer data. These are timestamps that are recorded for every time a patient moves in the hospital. Again, depending on your research, this can be really powerful. So we have timestamps for when you entered the hospital, timestamps for when your surgery started, timestamps for when the anesthesia for your surgery started, timestamps for when the wound was opened, timestamps for when the wound was closed, timestamps for when the anesthesia stopped, timestamps for when you were transferred into the ICU. So the point I'm making is that we have this very detailed information on where you are at different times in the hospital that you can really do some really interesting studies with the data depending on what you're looking at. We have provider data, information on who a patient saw and who they interacted with. There's user data. I worked with a resident on a really kind of neat project here where she wants to look at every time someone signs into Epic, a log is generated. And her research question was, well, how much time are providers spending logged into Epic and charting? And we did an interesting study looking at various times, at what times of day are people accessing the EHR system and doing charting, and how much time are they spending? Again, depending on, if these aren't fundamentally health questions, but if you're an operations researcher, you're thinking about things in different ways, there's some really interesting data with which to work. And finally, we can get to what we call unstructured data. So structured data refer to quantitative data in ready to analyze format. But as I mentioned, there's growing emphasis on incorporating unstructured data. This generally requires some type of processing. This is where AI, particularly deep learning methods, have become extremely, extremely powerful. So the way that I think about deep learning methods in particularly is that they are really useful when there is not a lot of noise in the data, but the signal itself is extremely complex. So we think about something like an image. Random pixels in an image are not going to be flipped or inverted or changed around. But the reconstruction of that image into something quantifiable is extremely complex. So things like convolutional neural networks are extremely powerful tools to turn that image that's unstructured into something structured. Similarly, we can think about notes. The written notes are, there may be some mistakes in there, but really there's not going to be, no one's writing a note and making intentional mistakes in there. So but that signal of what that means, that clinical note means, again, can be quite complex. So things like recurrent neural networks are very powerful tools. There's some great work in progress done by your colleagues here around the AI Health Initiative of really trying to break down how do we best work with these data. I'm going to so I'm not able to see any questions. Okay. What I think I'm going to do is I'll save some time towards the end and go through those questions. I don't want to pause too much. For some reason, I'm not seeing anything coming up in a chat box. I apologize.
I don't see anything either, but I can read
so
any questions for you.
Okay,
but
that's fine. Yeah.
Come in.
Okay. Okay. So
all right. So there is one question.
All right. Okay. Yeah.
Teresa called. If labs are sent to other locations, how are they entered back into the EHR?
Yeah. So that is a great question, and something that we're constantly. So fortunately here at Duke, a lot of labs are done in-house. For labs that are sent out, they are sent back. In older times, those may be scanned in as PDFs, and then they wouldn't really exist in a structured form. Now they are re-entered back in. So you may not get the results immediately. So for labs that are done in-house, for example, we may see a lab order time of 2 p.m. and a resulting time of 4 p.m. Labs that are sent out will take a couple of days to come back, but they do come back now within a structured form. But as you would expect, they come back in a different type of table, which depending on your knowledge of that structure may be harder to find. But we do get those labs that are sent out to places like LabCorp. Organizing data. So what I hope I've convinced you is that there's a lot of really interesting, exciting data to work with. What I've also hope I've kind of convinced you is that those data are going to be, are not in a format that you're going to want to dive right into them. So we can start thinking about organizing data. So there's various ways that, the informatics community has conceptualized how we organize data. The one notion and what we have here now at Duke is is creating what's called a data lake. This is a loose organization of data. It's able to maintain all data elements with no explicit linkage between data elements. I think someone's audio is on. If
please
sorry.
mute yourselves.
Yeah. If you can mute yourself, I'm hearing some audio in the background.
Users can end up wrenching and adding these columns if they want to look at it.
Okay.
Okay.
If you can mute yourself if you're talking on the phone. Thank you. No worries. So data lakes are a great way are a great way for an informatics group to organize data to make it accessible to high level users who kind of know that underlying organizational structure, because there's very few assumptions that are made about the data. We're keeping it as close to that raw format as we can as possible. While we're working, so the group that organizes data here, DHTS, are working on APIs to try to make the access to the data lake better and make it easier and easier for users. Most users are going to be more interested in working with what are called data marts. Data marts are data that are structured in a relational format. Think of like a SQL database, so some kind of relational database. These data are easier to access data. You typically, because of the simplification, we often need to make we need to make assumptions about the data. We need to reduce things and bring things together in different ways. So they're most typically well designed for particular use cases. So we may create, for example, a transplant data mart, which captures all the information on transplant patients, where all the transplant researchers may say, these are the data that we know we want about our patients, and this is what we care about. We care about diagnosis codes at these levels. We care about these labs, and we want these labs grouped together in this way. Where a data mart that is structured around, say, the maternal experience may care about different types of information and organize the data slightly differently. So these are structured data that are easy for access. They're broad use cases, so they're not one-off use cases, but they're meant to really work well for a particular use case. This results in a loss of information and as such kind of a slightly higher maintenance cost than a more generalized data lake. As we start thinking about data here at Duke, and now we start thinking about data at other places. So, most of this is really, I'm focusing on data that we work with here at Duke, but one of the appeals of EHR Data is how can I use data that I have at Duke and then talk with and work with a colleague at another institution who has similar data to do a multi-site study. That's where we start talking about the idea of data models, and this is a schematic that I really like, where we may think about, we have data from 3 different sources. Those data are structured in very different ways. We will transform the data to a data model, and after that transformation, now all the data have made the same assumption about the data. They've organized things in the same way, and now if this is Duke, UNC, and Vanderbilt, all different data sources, now I have my 3 data sources, and they now look alike, and now I can run analyses in parallel, or I can stack these data sets on top of each other to create a larger data set. So, so data models become a very powerful tool as we start thinking about how do we expand our research across institutions and across sites. The data model that we use here at Duke the most, I'll talk a little, is what's called the PCORnet data model. I'm not going to go in. This comes out of the PCORI an initiative, and it's an ancestor, a child of the Mini Sentinel project. Again, I'm not going to go into the details, but it's organized into really data tables that are useful for a researcher: demographic tables, vitals tables, encounter tables, lab result tables. And one of the data access options I'm going to talk about more in depth really builds itself off of this PCORnet data model. And it's a simplified model, but it's one that I think gives researchers most of the data elements that they'd want for most studies. So some advantages of data models are that they're simpler organization, they make it easier to access, a uniform set of decisions. There are disadvantages, this particularly being a general loss of granularity, where not all elements are fit within the data model, and many measures may be grouped together. So again, you need to, everything in life is trade-offs, and we need to be mindful of what are the advantages or disadvantages of the way we've organized and structured our data. But again, the point that I want to be really driving home is that we can't deal with the raw data. We need to make these choices at some level so that we can move forward and do the analyses we care about. So this is kind of, the first part in that, what is EHR data? What does it look like? The next phase, if you will, is, and which I'm guessing you already have an answer to this if you're listening to this talk, but is to really try to motivate, well, why do we want to use EHR data for clinical research? And this in some ways is, these are really my answers, and this is what got me excited about working with these data 8-10 years ago. So for one, as a statistician who has, the fact that the data are readily available is just a huge advantage. I can very quickly, easily, and most importantly, freely tap into Duke's EHR, pull some information, and just start running analyses. All I need is myself. I need a student. I'm not buying data. I'm not paying tens of thousands of dollars for data access. The data are there, and as Duke researchers, the data are actually there for all of us. I mean, these are our data in some regards, in terms of from a research perspective, to be able to learn from. And that to me is really exciting and powerful. Even more so, this is information, we may have information on hundreds of thousands or more of patients. I'll give some specific data from the numbers we have at Duke, but we have large amounts of information. As I've gone through, we have information over a variety of fields. This allows us to study many different clinical questions. So I consider myself very much a generalist, and I really like the idea that on the same day I can be looking at a problem related to diabetes, and then heart disease, and then surgery, and then transplants. And so I don't have, you have this ability to use the same data, the same knowledge base, to look across a whole host of different things. And also methodologically, they open themselves up to various methodological questions. So whether you're thinking about population health, or you're thinking about comparative effectiveness or risk prediction, these data support all different types of studies. And again, as someone who enjoys working with data, that's really exciting. Finally, and this is something that I'd say I've really grown to appreciate more and more over the past few years, is this idea that EHR data constitute a real population. It's something that I really try to impart on my students, is that when we're working with Duke data, we're dealing with real people. I do a lot of work with pediatrics. My sons are in those data sets. I don't know what exactly their MRNs, but I know that my sons exist in the data sets with which we're analyzing, and these are real people. Your friends, your neighbors, your teachers, your classmates may exist within these data, and that brings some realness to it. From a population health standpoint, one of the really neat advantages of a place like Duke is that, and again, I'll go more into this later, is that because Duke is a primary provider here in Durham County, there's a lot of really exciting opportunities for doing true population health research. With Giovanna, we're doing a study looking at the coverage of kids in Durham County and the demography of disease within Durham County for kids. And we can learn something from these data that relate to real people and real communities. This to me is in contrast to, say, a clinical trial, which, while very powerful in different ways, is an artificial population. Even large epi cohort studies are in some ways artificial populations. These are real people, real populations that you can map back to something truly meaningful. Why we may not want to use EHR data for clinical research is, again, this theme of the data are not organized for research purposes. The data exist in disparate places. All patients have different pieces of information. And the way that I talk about these is that these are your quintessential observational data. In some ways, I call them observational data on steroids, in that if you're not comfortable with the notion of how do I think about confounding biases, selection biases, you can make a lot of mistakes. And it's where I get most concerned with, people just diving into the data. You need to have a good understanding of how the data were generated, that data generation process, to know where some challenges and biases may arise. I think a lot of those challenges are resolvable or through either analytic approaches or really even thoughtful study design. So I don't think these are unavoidable problems, but you need to be cognizant of them, because the initial question you have in mind may not be answerable, but there may be a different way to restructure that question that is answerable. Okay. I think it's useful to think about, I'm not going to go in detail through this, you can look at this later if you want to, but I think it's useful to think about how these data may distinguish themselves from clinical trials data. So we have RCT data, and we can think about how the data were collected, when, who, and this can become ways that are useful to compare data. So just trying because I'm mindful of time here. Okay.
There are a few questions, but you want them at the end, right?
Yeah, you know what, I want, we go till, what time do we go? We go till 11, correct?
Yes, until 11.
Okay, so I'm going to be a little bit mindful of time here and skip a little bit ahead. I apologize. Again, we can think about different studies that we can do. I usually break down studies into notions of risk prediction, population health, comparative effectiveness, and association analyses. There are some advantages. So with population health, we can think about the advantage of being able to study on a particular community. For CER, this opportunity to see the real world usage of medical treatments. We can assess both adoption of therapies and effectiveness. And from risk prediction, there's opportunity to contain granular information capturing patients' clinical state, as well as, and this for me again is really exciting, a direct pipeline to implement models into clinical practice. This is a slide that I include almost in every talk, is this, we need a notion of collaborative clinical research with EHR data. We need, there needs to be a biostatistician involved who's thinking about the analyses, informaticist who has an understanding of the data extraction, and an epidemiologist or clinician, or just a subject matter expert who knows that research question. And then all these folks really come together to think about how we work best with these data. So in summary for this part, let's say the EHR systems are complex ways to store patient health data. For clinical researchers, there's a lot of appealing reasons to want to work with the EHR data, and the raw data elements need to be processed, typically through hierarchical structures, and then organizing data into data models can aid analytics. In the interest of time, I'm actually going to skip this section. I really encourage folks, these slides will be posted on the DUPRI website. I do encourage folks to, if you're thinking about working with these data, to look through this a little bit. I do the different problems with working with EHR data. I do want to highlight the 3 problems, not go into detail on them. There's the 3 challenges that I often think about are, we don't have everything we want. We need to link in outside data. Outcomes are not well defined, so we need to phenotype data, create what are called computable phenotypes, a really important problem. And then how we deal with data that are irregularly or potentially densely captured. I don't want to go through. Yeah, folks can look at this on their own, but I want to get to what I think people are probably most interested in, which is how we actually access data. This is a little case study. So this is an R21 we have looking at impacts of asthma exacerbation in children. Kind of gives you a sense of how we, how you may structure an EHR-based research question. Again, I'll let folks spend a little bit of time on this on their own. I think this is probably the topic that people were most interested in, which is how do we actually go about accessing EHR data at Duke? So hopefully I've convinced you that these data are interesting to work with. I've unfortunately ignored the fact these data can be hard and analytic challenges, so you'll go back on that on your own. But this is how we actually get the data. EHR data at Duke. Duke University Health System, DUHS, consists of 3 hospitals, 2 in Durham and 1 in Raleigh, and a network of outpatient and specialty clinics. The EHR system here is managed by Duke Health Technology Solutions, or DHTS, and they're responsible for meeting both the operations and research data needs. So they really have a dual function of supplying data to the hospital, organizing the EHR, keeping it up and running, providing information back to people in billing and other groups, care management. But then they also have a university school side component that is meant to service data needs for researchers. Duke finished switching to an integrated Epic-based system in August 2013. Before this, different departments had their own EHR systems. We often refer to this as legacy data. So this pre-2014 data is legacy data. They do exist, they are accessible, but they're messier, they're less reliable. I generally try to avoid using legacy data, particularly now that we have up to 7 years of data going back to 2014. It's becoming less and less important. Depending on your research question, you may still want to use it, but there's again, there's more of a buyer beware component to knowing what you're getting involved with there. For the most part, 2014 on data are going to be much more researcher accessible. EHR data at Duke are big data. So since 2014, there have been over 1.7 million unique patients, over 400,000 inpatient encounters, over 27 million outpatient encounters. And these patients each have diagnoses, vitals, labs, medications, orders, et cetera. So a lot of information, a lot of exciting things as researchers we can do with these data. These data are also really exciting from a population health standpoint. So DUHS is the primary provider of health services in Durham County. This is work with a graduate student of Giovanna's, Alison Stoldi, where we've estimated that about 80% of Durham County residents, particularly children, get their health services at DUHS. This is a map based on census tract of coverage. One hole, and it's actually a really important hole to note at Duke, is that there's Lincoln Community Health Clinics, which is a federally qualified healthcare provider that serves an underserved population. They share an EHR system at Duke, but special permission is needed to access their data. We are working on data use agreements with them, but you may not see data, particularly if you think about population health, you may not see data from the poorest members of our community who are more likely to go to Lincoln Health Clinics than they are to go to a Duke primary care. But to give you a sense of population health and how it can be used, there's the Durham Neighborhood Compass Initiative, which essentially uses Duke EHR data to inform about public health in Durham County. And you, if you click on this link, you can look and see, mappings of different diseases within Durham County. There's a need for pre-requirements. So I always like the Spider-Man adage of with great power comes great responsibility. Most forms of EHR data contain protected health information. As I mentioned, most of these patients are your neighbors, your community members. So these truly can be non-anonymized. And while data are available for minimal risk research purposes, it's important to protect the identity of patients. We can get data as what we call fully identified. This may have names, date of birth, addresses. These are things that you'd go through your IRB and you have to make a justification for why you needed it. So the general principle is that you should use the least amount of PHI that you need to complete your study. I would say for myself, I typically find myself using date of birth and address. I can only think of one study where I've ever needed to look at names, for example. You can create limited data sets, which will have minimal PHI, typically dates of service, or de-identified data, which have no PHI. And can technically, those are data you can store on a laptop because they're completely de-identified. There are pre-requirements to being able to access data. So the first is city IRB training, and the School of Medicine has particular IRB training modules that you have to take. So even if you've gone through the IRB training on the university side, you need to go through the School of Medicine IRB modules. You need an active IRB that's been approved by the School of Medicine. So again, this has to go through the School of Medicine IRB approval process. Typically, the data need to be stored in a secured, on a secure server. While data can be sent to university side servers, the most typical server, which I'll talk about, is what's referred to as PACE, and data to be stored there. And depending on the degree of direct access, and if you're going to get PACE access, you need to have what's called a Duke Health account or a DHE account. A DHE account, it's not that hard to get, but the main initial step is that somebody on the School of Medicine side has to initially sponsor you. So it's a very easy process for a university person, but you do need to have sponsorship by somebody on the School of Medicine side to initiate that process. There's The DHTS has created what's called the Protected Analytic Compute Environment, or PACE. It's a HIPAA FISMA compliant virtual machine. Essentially, you can get one that's either Windows-based or Linux-based. Essentially, what you get is the equivalent of a laptop. You get a virtual machine that has the equivalent resources of a laptop. You can easily get data in, but you need to go through an honest broker to get data out. So that's the secure aspect of it, that you can't remove PHI. You cannot connect to the internet from it, but it's preloaded with R, Python, SAS, GIS, most analytic tools that you would want. And if it's not, your analytic tool is not there, they can usually add it for you. While the resources are equivalent to a laptop, you can connect also to, there are partnerships being created with Microsoft Azure. I believe also there's an AWS connection, so you can access to GPU machines if that is necessary for your analytics. What I actually really like PACE, but I've kind of grown to really appreciate about PACE, is that the directory structure is based off the approved IRB protocol. So this means that everybody in my project team, all my students and staff, they're working off the same shared environment. So all of the data are shared in one place, all the code is shared in one place, and they can all work off it together. I'm going to talk about 3 points of access. In reality, there's more points of access here, but these are the 3 main points of access to get EHR data. So we have a self-service tool called Deduce. This is a GUI-based tool. There are code-based tools, and I'm talking about one particularly called the CRDM, which is one I've personally been involved in developing. And then these are both self-service options, and there are the option for getting expert-assisted access to work with a group within DHTS called ACE that can provide data to you. So, and I'm going to emphasize mostly the CRDM because that's what I've worked with. But to make aware, so Deduce is a GUI-based system to query data. It's probably the easiest way to access data. You build a cohort via hierarchical queries and indicate which elements to extract. The biggest challenge of this is that because of its GUI nature, the order of operations can impact the way the cohort is built. So depending on how you begin to filter out your data set, if you put, I want men before the age, you may get something slightly different. And so it doesn't, and because it's GUI based, you cannot run your queries repeatedly. So therefore, it doesn't have a high degree of natural reproducibility. It's really good for kind of a quick one-off, low cost access way to get initial data. It's something particularly if you don't have a lot of coding and skills that you want to just look at something quickly yourself, it could be quite useful. The data in Deduce do go back to the 90s, but data pre-2014, again, may be less reliable. Partially in response to some of the limitations of Deduce, I've been part of a team where we've built out what's called the Clinical Research Data Mart, or the CDRM. This is an offering that with joint support from the Children's Health and Discovery Initiative, Translating Duke Health, CTSI, and DHTS. You can access the website here. It's designed to support clinical research and development of clinical registries. We built this to meet a few principles. First, that data pools need to be reproducible, to provide a code-based access to a broader range of analysts. We've kind of, when we structured this, that most data queries don't need the most up-to-date data. So there's a lag in some of the data right now. We're working to resolve that lag, but there is up to a 2 to 3 month lag in the data you can get, but most research purposes, that won't be a problem. Most studies use many of the same data elements, ICDs, labs, medications, and that the data should be linkable to other data assets, such as department-specific data marts, publicly available contextual data, et cetera. So, and this is going through active development with new data tables to meet researchers' needs. For example, we're working on a family linkage table as a response to needs from COVID researchers right now. So the CRDM is organized as an extension of the PCORNet Common Data Model. So as mentioned, PCORNet contains most data elements. We've added additional tables such as provider information, encounter details. I'd say the biggest hole in the data are you don't have details on the hospital encounter, so there's no timestamps around bed flow, timestamps of vital signs. So if you really need that granular hospital encounter, this won't be the data source for you. It only contains data starting in 2014. The data are refreshed and quality controlled and quarterly, and then what we're working on is a way to create a daily refresh. And the data sit within an Oracle database that can be accessed from within PACE via R, Python, or SAS. So what I really like about this is that I can write code I'm an R person, I can write code within R. I can use RDOBC to create a SQL connection to the Oracle database, query, pull the data into my R environment, and then run all my analytics. And now I have a full code base that's fully reproducible, that I can regenerate that code as often as I want to pull in data and rerun analyses. Again, a kind of a basic structure is that we're taking Duke Health data, we're moving it into the data model, and then off of this, we would have each individual projects, which may also bring in geospatial data, department-specific data marts, or other types of data sets. To get access to the CRDM, and I believe I may do in the fall for folks who are interested, through DUPRI, a more kind of detailed how do you access CRDM. You need to obtain IRB or RPR approval to access EHR data. You need a PACE account. We ask you to fill out a red cap registry so we can kind of track projects. And then after that, you just need to reinitiate the connection. And once you have that connection, you're free to pull data as your IRB would allow. I'm not going to go through this, but these are a variety of use cases across various fields that we've been using the CRDM for. And then finally, we have ACE fee for service. So this is a component of DHTS. And this is a team of informaticists who can perform custom data pools and data services, building out data marts, creating APIs for you. The first two options are ostensibly free services. The data are there for users to access. This does require paying someone to do the work for you, and cost and time is largely dependent on the complexity of the data domains requested. This is most useful when you need unstructured data elements or detailed hospital flow data. I'm not going to spend too much time. I want to leave a little bit of time for questions at the end, but it kind of gives you some comparisons about how these data versions may differ. And again, I tend to be a believer that all options have a good use case. So this is a lot of information. So the question often comes up, how do I navigate this? I encourage people, to look at the data services catalog, which can help people navigate clinical services here at Duke. So this is the website for the data services catalog. It gives information on a whole host of data that are options here at Duke. I'm thinking about this, Giovanna, we should probably add some of DUPRI's data to this, but data from Population Health, data from Cancer Institute, the Clinical Research Data Mart, DCRI data. So this is a great resource for folks to find out information, to get specific information on navigating the EHR system. DHTS has put together the EARS group, which stands for EHR Enabled Research Support Group. Again, it can help users, really help them to understand how to navigate the system and help connect them with the right data resources that are there for their project. So in summary, I hope I've convinced you all of is that the Duke EHR system contains a wealth of information on patient health. The data present opportunities to study population health within Durham County. This is an area where we've done some really exciting research on. And EHR data can be quite complex, both structurally and epidemiologically, and that there are multiple ways to access data here at Duke. I'm gonna see if I stop sharing, if I can see some of the, okay, now I can see all the questions. That's
you can see that. Well, then you should take them starting from E1.
Okay, so I'm gonna take,
exploring.
Okay, okay, a lot of people telling me how I could have done this. I got posted, the host can, okay, so what's the process of exploring either data lakes or marts to get the right data for a specific question? So So there's a variety of data marts. I'm going to talk more about data marts. So there's a variety of data marts that exist across the School of Medicine. As I mentioned, a lot of departments have created their own data marts. So for example, OBGYN has created what they call the Stork universe or Stork data mart, which covers information about birth encounters. So if you're someone who's thinking, I want to know something about birth encounters, I want to do research on birth outcomes, what you really have to partner with around is somebody within OBGYN and understand what data they've organized and pulled in. And so those are more the department specific data marts. Heart Center has their own data mart, Transplant has their own data mart. We can also think about then the data, I would put the CRDM as a more generalized data mart as well, which will, which kind of gives a broader access. But if what you desire are those really specific types of data structures or data elements, partnering with those particular departments is at this point is likely the best case. Is billing data or cost for easily available? No. So there is obviously a lot of billing information. There's a lot of cost information. For obvious reasons, those data are not readily available to researchers. Those data can be available for particular use cases and contexts. I've personally worked with our billing data and our cost data. We have restrictions on when we can publish with them or not. Those are really more what we would call for QI or quality improvement purposes. What about EMS and pre-hospital care data? Is that easily accessible in the formats you described from Epic? Yeah, so, and that's actually really interesting because, so again, the project I mentioned around traumatic brain injury, we're particularly thinking about those data. Those data typically exist in unstructured form. So pre-hospital reports, EMS care, those are not going to be organized within structure, currently typically within structured data elements. Just to double check, family members can be linked, right? So this is actually a really timely, pertinent question. It's something that we're actively working on. So, and it's nuanced. The only time that family members are linked is at the birth encounter. So at the time of birth, a mother and child, their MRNs are linked at that time. After that, there's no explicit linkage of family members. Now, that being said, there are ways that we can start thinking about family linkage with EHR data. There are fields within Epic that allow you to mention who your mother, your father are. They're not well populated, as you may guess. There are fields that allow you to mention emergency contact, which may or may not be a family member. What we're actually working on is trying to look at how can we use addresses to, and what I don't like calling it family members, but I like calling it cohabitation. So in principle, we can look at two people who are living at the same address at the same time and say they're cohabitating together. Now, I don't know if that's a brother and sister or just two roommates, or I don't know if it's a father and son or an uncle and nephew, but we can look at people who are living together at the same time. Depending on your research question, that may or may not be enough for you. So what we're looking at, for example, in the COVID world is adults who test positive, can we identify children who are living with them to do proactive outreach? But there is no explicit family linkage aside from the birth encounter. How does OASIS research factor into those that you listed? So OASIS is a relatively newer organization within Duke. That is a team to help organize data. So they put together the Duke data catalog. There's informaticists within OASIS who can help users get access to data. Can OR data be retrieved? Anesthesia type time ASA code, absolutely, yes. So we're working actually on a COVID related OR project right now, and we have extremely granular data on the time when anesthesia started, the dosages of anesthesia. Anesthesia itself, anesthesiology is actually one of the more interesting informatics groups in the sense that historically anesthesiologists have organized data much longer than other groups. So there's actually a standing anesthesiology data mart that has really granular information on intraoperative vital signs that goes back pre-Epic data. So there's a lot of really great anesthesiology researchers here who are very informatics data savvy. So yes, there's a lot of really great OR data available. Okay, comment on the recommended approach for converting EHR data into a tidy data set suitable for analysis and the importance of a priori hypotheses and a SAP to protect against p-hacking. And yes, so I definitely glossed over how we go from a data mart to an analytic data set. That was in the slides I skipped. That's a process, and that's kind of where I think about the handoff from the informatician to the biostatistician. So the informatician is extremely well skilled at pulling data, getting data out to you into a and then the job in my mind of that biostatistician is say, what is the particular research analysis I'm doing and how do I organize that? And for every analysis you run, those data need to be organized in a slightly different way. So that in and of itself is a second layer process. It's why I actually like the CRDM environment, is because I can organize my informatics code with my statistics code. So my informatics code, if you will, is my querying of the SQL database to pull data into my R environment. That immediately feeds into, say, DUPRI, which then turns all those data tables that I've queried into an actual analytic data set. And yes, from the importance of a priori hypotheses, we're in the world of big data. You can ask lots of questions and you need to be cognizant of what is the way you're organizing your data. I think, and the way you're designing your study, these are great for exploratory data analysis, but I actually get almost sad when people think about these data and only want to do descriptive analyses. You can really do inferential analysis with these data. I've been working with the FDA. I'm a big believer that we can do drug approval, drug safety monitoring, comparative effectiveness with EHR data. But if you're going to do that, you need to be very responsible with how you set up those research questions, use best principles of study design, statistics, etc. But there's a lot of really great inference that can come out of this. So some data marts owned by a particular department is closed to certain people, meaning not available for all to conduct research. I don't want to be, so I would say that they require partnership. So I'd say departments have invested in creating data resources for their departmental faculty, and for a variety of reasons. A lot of it is substantive reasons. I think there are legitimate substantive reasons why they don't want to just hand over data to other groups, because they may not misunderstand it. So I say there, but what I would say, and I think this is a culture of Duke in general, there's a very strong collaborative culture where you may not be able to just be given access and free rein to a department-specific database, but collaborating with people, particularly if you're a technically oriented person and have the analytic skills, to partner with someone who has those substantive clinical skills can be really powerful. So what you have in most of these clinical departments are clinicians who know the data really well, but maybe don't have the analytic skills or to analyze it and manipulate it in the right way. So I think there's a lot of room for really strong partnerships. Who would be a contact if we were interested in extracting data, DHTS? Yeah, so if you're interested in extracting data, there are various ways to hit the EHR data. I encourage reaching out to EARS, for example, if you kind of want an overview of the process. If you kind of know that you want to go, if something like the CRDM makes a lot of sense for you, you kind of know that these are the data that I need, and we're working on putting together some training modules for that, then you can directly access in that regard as well. What is the process for linking to department-specific data, CRDM to department-specific databases? So that's something that we're actively working on right now, is creating those partnerships. So the ideal structure of the CRDM is that we have a full denominator of all patients who've come to Duke, but maybe we're missing some of the contextual information. So we don't have, for example, ejection fraction in there, but the heart center's data mart does. So what we're now working, and similarly with birth encounter, we don't have all the details on the birth encounter, but the Stork data mart does. So I say that the next phase within the CRDM is how do we begin to create those linkages so that you can start querying across those databases. A colleague of mine, Nupin Bhavsar, is working on organizing GIS data and American Community Survey data, so again, it'll be more directly linkable with these data sources. With the current Duke data system, are you confident that all pieces of info are pulled completely, or is it possible that certain pieces of data are not pulled? So great question. So I want to repeat that, make sure. So am I confident that all pieces of info are pulled completely? I often say there is no truth in EHR data. I do not believe, if you asked me how many diabetics there are in Duke's EHR system, I don't believe there is a true number. I believe there's a true number that exists. I don't believe we can ever know that true number. And so much of it is dependent on the data that I pull, the way I pull it, the way I define things, the way I define what a diabetic is. So I didn't have a chance to go into detail about creating computable phenotypes and data definitions, but there's an entire process of how we create data definitions. So I'm not a believer that there is a truth that we can ever find. What I am a believer in is that whatever process we define for pulling data, we need to be consistent in that process. So I believe more in reproducibility. So we may not always, so you may define a process one way and I may define a process another. We may get different answers. That to me is okay. What we want to be clear about is that every time we do something, we do it in a consistent way. And one of the things that the Duke Health Enterprise is becoming more conscious of is that as an enterprise, we want to be doing more and more things in a consistent way. So as we start thinking about data structures, we don't want to be relying on all different types of data structures. We want to have centralized data resources so that everybody's pulling data from the same place, so that we get more and more similar answers. So if you're pulling data from one environment and I'm pulling from a different environment, we may get different answers. If we're pulling from the same environment and using the same processes, hopefully we'll start getting the same answers. So this notion of truth is quite complicated and subtle. We have a de-identified data set created by ACE. Is there a procedure to liberate it from PACE? I like the word liberate. So in principle, if you've de-identified it, then you can go through the honest broker and you should be able to extract it out. That being said, it also depends on your IRB. So you need to have, that IRB needs to specify where those data can exactly live. What's the process of linking EHR data, Durham County administrative data in other domains, to Durham County administrative data in other domains? Again, that's something that we're working through as well. I know DUPRI has done a lot of great work in terms of organizing various forms of administrative data, right? And one thing that I'd love to see is a greater consolidation of really how do we bring those data sources together. There are some data that we're not allowed to link together. For example, school records data. The Durham Public Instruction, DPI, has interpreted state law that says you can't link biometric data with biological data with school data, to mean that you can't link EHR data with school data without explicit approval. So some administrative data sources we can't link together, but what we are trying to figure out is how can we bring more and more of these data sources together, and that is an active area that we're working through. Are waveform data being captured and stored in Duke EHR? ECG data. I'm not the best person to ask for that. I know that my understanding is that it's more and more so. It doesn't go back historically. I know it's something that groups are actively working on. It's not an area that I work as specifically, so I haven't encountered that as an issue as much. I believe that it's starting to. I know you can capture it prospectively. I believe that there are data marts that are organizing it. If anyone knows that answer, please feel free to chime in. I'm not 100% clear on what exactly the status quo right now is for waveform data. Any other questions? Okay. Relinking with school records, even linking by zip code is not allowed. Again, I'm not sure about the zip code. Again, I'm not sure. Also, I'm not sure what that would tell you, given the fact that kids in Durham at least go to a lot of different places. So in principle, you can use aggregated data, right? So if you knew something about a community school, the school in your community, you can link that. And if you wanted to make it, you can use that aggregated school level data linked to kids in that community. That being said, given the nature of schools in Durham, where kids go to a lot of private schools and go to non-community schools, charter schools, I'm not sure how useful that would necessarily be. And yes, no, Giovanna, if you can post where they'll be perfect. Thank you. Yes, no, we'll get the slides posted. This talk will be posted. And my hope is that this actually is not the end of a conversation, but the beginning of a conversation about how we access to EHR data. My hope and intention of talking with Giovanna about this is in the fall to do a more specific training around how we access the CRDM. So if that's something you're interested in, what I'd encourage you to do is begin the process of getting the access protocols so that we can do a hands-on training. I see Suresh chimed in that there is no waveform data, but the infrastructure is being developed. And that was my understanding, correct? Thank you. And again, my email information is very easy to find. Please feel free to reach out to me as well, and I'll probably connect you with somebody else who can help in any way too. But there's a lot of great people who are thinking about these data in a whole host of different ways. I think there's a great opportunity for partnerships here.
Thank you very much, Ben. This was very informative, and there will be more of this, so stay tuned. I posted the website where the talk will be, or the link to the talk will be posted within about a week, and we'll keep everybody informed on sort of the next event, hopefully in person, given that that might be a hands-on easier probably, but you know, in the fall. Thank you everybody for coming. We had 68 participants at the peak.
Thank you for doing it.
Thanks.
Thank you, Ben.